and I am currently the Director of Programs at Palliative in Trivandrum. Today, I'm going to be speaking about psychosocial evaluation and management in palliative care settings. And this is a particularly important topic to us at Palliative because as part of an interdisciplinary team, the expertise that is brought by psychosocial clinicians is absolutely essential in the total plan of care that we create for our patients and their families. So to begin, the World Health Organization defines palliative care as an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering, and by means of early identification, impeccable assessment, and treatment of pain and other problems, physical, psychosocial, and spiritual. You'll notice that some of the phrases are highlighted in red, and those are some of the phrases that we feel are significantly relevant to what we're going to talk about today. And not only do we talk about relief of suffering, and we also talk about prevention. And prevention, we feel, is a very, very significant dimension of the work that we do. And a lot of suffering can be prevented if it is assessed early enough. And just as in medical practice, even in psychosocial clinical practice, assessment forms the foundation of good practice for us. And an effective plan of care can only be devised if there is impeccable assessment that is done. We also highlight physical, psychosocial, and spiritual, indicating that it's a multi-pronged approach. It's a holistic approach, and all aspects need to be looked at in order to prevent and relieve suffering. So why psychosocial care? Why do medical professionals need to be familiar with psychosocial care and what psychosocial care entails? Firstly, we need to acknowledge that living with a life bounded by the person's life circumstances. Now, what does that mean? Here I'm going to ask you to imagine that you wake up with a headache one day, and on that particular day, you're able to take leave from work, stay home. There's somebody at home to look after you, cook up a meal that is comforting, and you're able to rest and relax. And on that day, if I were to ask you what your pain was, let's assume it's at 3. I'd like you to imagine another scenario where you wake up with a headache one morning, but on that day, there's no way you can take leave from work. You have to go to work. You have several deadlines that day. and somehow on the way to work, your mode of transportation breaks down. You find it difficult to get an alternative, and then by the time you get to work, you're late. There's people there who are upset with you, and your deadlines are not being met. So on that day, if I were to ask you what your pain scale was, your pain score was, I imagine that it's very likely to be more than 3, because your life circumstances have contributed to that headache feeling so much worse. So that is actually a very simplified that have been financially devastated by treatment costs. And so we look after the educational support needs. And in this case, we sped up the whole process. It usually takes about a week, but in this case, we went back and we found people to make pledges, and 2 people signed up to see these 2 children's education through to college and so on. And the next day, when we went back to see the fisherman, when we first asked him what his pain was, he said it was still 6. But once he was shown the documents, and once he was told that the children would, not have to discontinue their education. In fact, their education fees was covered right through to college. There was a transformation in his face. And then once we allowed that information to settle in, and we asked him again what his pain was, he said 1. And I can't think of a more illustrative story than that to really show you what total pain looks like. And that is not just a one-off, that has been our repeated experience. So as a clinician, really, my responsibility is to assess the contributive factors leading to total pain. I need to look beyond the physical and ask and he's a daily wage worker, and her child is 6 years old and is going to school. So what are the important areas to be assessed from the point of view of total pain? The aim of the assessment would be really to identify areas which result from illness and may influence problem areas which result from illness and may influence the well-being of the patient and their family. And this assessment also, of course, apart from collecting information, we use this information to identify and honor the strengths that the person and the family already have, the resources available to them, and what their needs are. assessment and gathering of information is an ongoing process. So this is not a one-time thing. So typically what this looks like for us is when the patient and the family come in, we try and understand who forms the family system, who forms the support system. We draw out the genogram, which everybody is familiar with, but not only do we draw out the structure of the family, we also try and find out what the dynamics are between family members. We try and find out if there's any tension within the family. We try and find out who the cohesive units within the family are, who speaks with whom, and in what manner, who holds decision-making structures available to them. And this is something that is an ongoing process. So as we go along, we first, of course, have to develop rapport with the family, and slowly we delve into to the deeper aspects of their lives. We will, in time, also explore intimacy issues, if that is something of relevance in designing a plan of care. For instance, in the case of young people who have come in to our care for spinal cord trauma and require and have palliative care needs, and very often, some of them are very newly married, or they've been married just a few years, and intimacy issues might be a problem within the spousal system, and that is not something a lot of people are willing to talk about, but it is a cause of severe distress in many cases. So as we develop rapport, we go into some of the more you know sensitive territories. We also talk to them about their spirituality, and I don't mean that in a religious sense. We talk to them about what brings meaning to their lives and so on. So it is a definite how they also relate to one another. There might be changes in role responsibilities. If the person who is unwell is the mother, and she had a particular set of responsibilities that she carried out, which she no longer can, and somebody else has to fill that gap, and it's not very easy. So these psychological needs keep changing, and we have to adapt with them as they go along, and in certain cases probably prepare them for the changes that might be coming up. Assessing psychosocial and spiritual suffering. And this is not just, these conversations that we have with our families and the patients are not just, rambling conversations which allow them to just vent their emotions. These are very purposeful conversations. There are certain goals that we try and set. The multidisciplinary team gets together. We talk about where each of us sees the measure. They can sometimes be difficult to recognize and treat. And in a world that places so much value on evidence-based research and proof uh, of something existing, this can be a difficult terrain to navigate. Having said that, we're all human and we recognize each other's frailties, and of course, this is where we look at psychological impact of an illness or even spiritual impact of an illness. Very often, living with an illness or being diagnosed with an illness is accompanied by feelings of shock, uncertainty, loss of hope, and despair. When somebody is given a diagnosis of a potentially life-threatening or life-limiting illness, these are very common emotions that a person goes through. And the uncertainty of what is about to happen often results in a feeling of losing control of one's life. And that loss of control can be a terrifying experience, especially for somebody who has placed value on being And of course, anticipatory grief also applies to the loss of the life that's coming. And the people that you're going to be losing. And this is something that caregivers will be particularly intimately familiar with. When you look at the person you're looking after, knowing that they're going to die, and you imagine what life would be like without them. So that is anticipatory grief. Poor insight on diagnosis and prognosis can cause a lot of distress. And this is really something that we as health providers, healthcare providers need to take responsibility for, where often I find, people who have not understood what the diagnosis diagnosis is or what the prognosis is. And I think here we as the professionals and the providers of care need to look at what language are we using when we are communicating with our patients and families. Are we using a language that they're unfamiliar with? Are we jargonizing the language? We are able to, get to that place with the patient and say, tell me what your fears are. Tell me what exactly it is that is scaring you so much. And we find that the answers might range from, will I be in a lot of pain? Am I going to be breathless? I don't want to be breathless. Or some people might be worried that they lose control of their of their cognitive faculties, and that they might say or do something that is embarrassing or or terrifying to their families. So in that case, our job really becomes to assure them that no matter what they go through, we will be with them. And we will do our best to reduce the suffering, or to reduce the distress that they feel, or their family feels. And that really is what reassuring somebody with hope is all about, because very often a person is told that there is nothing more that medical science can do for them, and that's really the death sentence that they're given. But in palliative care, we believe individual level as well as on the family level. And evidence shows us that if a family was dysfunctional to begin with prior to a crisis, that dysfunction is usually enhanced and amplified once there is a crisis of illness. So if it was a family where there was a lot of infighting, a lot of disagreement, then that disagreement and infighting is likely to grow manifold when it comes to a crisis situation. Similarly, people could have poor coping styles, even prior to an illness, and of course the illness amplifies that as well. So these are things that we can explore. It's important for us to look at the history of the family in terms of how they were before the illness, and how they coped with crises that were not so life-threatening, and that will give us an indication of what their strengths and possible areas where they need our support are going to be. So psychosocial and spiritual suffering can manifest as physical complaints, and I think we can all be in agreement of that. If somebody is, this is just the idea of total pain all over again, but also psychosomatic conditions like who are the persons or communities you look to for support? What role do they have in your care? Do you have an image of a power greater than yourself? Has your life situation now affected your feelings about yourself, your faith, or your relationships? Meaning and joy. What has been the most important in your life? What are you most thankful for? What makes or has made you happy? What do you feel the proudest of in your life? In strength and comfort, the question is anything that is comforting to you now? What helped you get through difficult times in the past? Who and what is your source of strength now? And hope and concerns. Is there anything that you hope for? Is there anything that feels unfinished? If you look at the tone of these questions, not only is it taking the attention off the illness and into other parts of their lives, which is something that is really important. When a person gets sick, very often all conversations revolve around the illness. The illness becomes a focus and central point of that person's life, and it's very easy to forget some of the other important things. Now, these questions really reframe or bring you back to that. The other thing that these questions do is also encourage the person who's being asked the questions to look at their lives from a more positive and meaningful way, and to sort of reacquaint themselves with what has given them strength and meaning and courage in the past, and to draw on those same things again now, which it's very easy to forget when you're fighting for your life. So there are several valuable aspects to the spiritual assessment tool. And I would really encourage anybody who's going to use it to do a fair bit of reading up on it, one, and secondly, to try assessing future. And there seems to be a generalized fear that has come in, and this generalized fear is something we see a lot in people who are not clear about their prognosis. They don't know what's coming, they don't know what's happening, and so there's this generalized fear where everything is actually scary. Socioeconomically, because the husband has to stay home and look after her, and he's a daily wage earner. On the days that he's with her, he loses his wages. And of course, there's worries about the education expenses of her child. And she lives in a very rural area, and so access to the RCC or the hospital is very tough. And finally, in terms of spiritual dimensions, she's in extreme spiritual distress, and she couldn't understand why she had to suffer so much in spite of being a strong believer of God, and a loss of connection with family and friends and the community, leading to further sense of isolation and a loss of interest in pleasurable activities. Now, this could be, I mean, a lot of people would interpret that as depression, which would be a psychosocial element, but it can also be seen as a spiritual element. So very quickly, we need to touch upon the idea of dignity, because that is so closely tied with personhood, and personhood is often under attack when someone is sick. The inability to acknowledge personhood, the insensitivity of not acknowledging personhood, can be psychologically devastating. Harvey Max Georginov is the author of the book Dignity. Really what this talks about is the ABC is our behavior, our attitude, our compassion, and the dialogue that we initiate with our patients and their families. People experiencing a loss of dignity have significantly higher rates of depression, anxiety, and feelings of hopelessness. This is a well borne out study, like I said, and if you know, sometimes as a clinician, it's very hard to prioritize what needs to be attended to first and given most amount of time to. But time and again, we find that it boils down to a sense of dignity that the person has also. So if we go right to the source, then a lot of other things also get taken care of. This is by no means absolving us of the responsibility of actually checking in to see, to screen them for depression or anxiety and so on. But this is definitely a dimension we need to add to our practice in addition to what we already do. Is what I mean to say. The dignity question is really, what do I need to know about you to help you better? That can guide our practice. These are by no means questions in their final form. You're welcome to play with the questions, contextualize them, or to simplify them. Depending on who you're talking to. These are just some things that will help us shift our own perspective and our own lenses. So in terms of your illness experience, How do you define dignity? This is something to ask our patients and their families. Have you felt that people have respected your dignity here? What supports your sense of dignity? What are we doing as a team that is supporting your dignity? What are we doing that may be actually, offending you a little bit? Do you believe that dignity is something you hold within you, or is it something that can be given or taken away by others? This is not really a question that you need to ask exactly in this manner, but this is definitely a question for the interdisciplinary team to delve on a little bit. So if a person believes that their dignity is something that they have control over, then they can still hold on to it no matter what the circumstances. But if they feel that what will people remember them by? What have they left behind for their children and for future generations? Have they left their mark in the area of work? And legacy building is part and parcel of dignity therapy. And we do this in different ways. A patient might be asked to speak into a tape about various aspects of life they would most want permanently recorded and ultimately remembered. Things which they feel are most important and they could most want and they would most want their loved ones to remember. This could also be used innovatively to leave messages for people for particular milestones. Like there are so many stories of patients writing letters for their children on particular milestones as they grow up, because they won't be there for those milestones. For example, graduating from school or getting married or having a child of their own. And this is a way to sort of continue to be a part of a loved one's life. And also it gives a lot back to the family member to hear from people who are deceased but beloved to them. And so there are various ways in which legacy building can be explored and brought into our work, and this really gives a sense of dignity and restores it back to patients and families. Between the family and the healthcare providers don't end with the demise of the patient, but go far further. The healthcare system, the healthcare provider continues to be in touch with the family well after the patient has passed away, providing bereavement support. and typically there are 2 to 3 follow-ups that happen. And families are then invited to be part of the bereavement support group, which we have found to be extremely helpful and useful to families. And many of them keep coming back to the bereavement support group for years, and then become very active members in helping other people who are newly bereaved. Recommendations for government schemes and other financial assistance is particularly relevant when we are dealing with patients and families that are not doing very well economically, and or for whom the healthcare, the cost of healthcare has also further devastated them financially. And our role really is to liaise between the government schemes and them and allow them access, or help them get access to these schemes, making their lives a little bit better. Linking with community resources. This could be with volunteers in the community, ASHA workers. It could be with the panchayat, trying to get them certain amenities, or trying to get certain subsidies for them, or even like in terms of educational support, identify some of the ways in which vocational rehabilitation is provided in different contexts. We had a lady caregiver who asked if we could help her get some goats that she could rear and at the same time stay at home. We had another patient who wanted to make pens, and that's him making pens. Providing women with sewing machines, and so that they can stay home, stitch, sell what they stitch, or do some tailoring work. That allows them to be at home and look after the person that they're looking after. And the last picture is of someone who has quadriplegia. He makes umbrellas, and he's been doing this for a couple of years. Now, and he's really been able to sustain himself financially. We also provide support for children and for education as well as emotional needs. For us as clinicians to remember that we evaluate our interventions. And it's not just, if we are going to give that lady a bunch of goats to look after, we need to go back and evaluate whether it was the right thing that we did, or did we just add to the burden of her duties. I mean, that's just one, but we need to evaluate all our decisions and all our interventions and review them to see whether they're actually beneficial to the patient or not. Good documentation is invaluable, and this is something that is to be taken very, very seriously, because just as it is important to track a medical chart, similarly, it is important for us to track our psychosocial interventions, our spiritual interventions, and to know what has worked, what has not worked, and to make sure that goal setting is done carefully based on past history. Wherever possible, use research validated techniques. I mean, this is just obvious. This is not something that needs to be overstated. And just as there is an